bit about LTCCC, if you're not familiar with us. We are a nonprofit, nonpartisan organization entirely dedicated to improving care and quality of life for individuals in nursing homes and assisted living. And also, as I was just talking about, we do work around dementia care to support better dementia care for individuals no matter where they live. Most of our work is focused on policy research and analysis. A lot of that incorporates data, particularly data on nursing home staffing, care, quality, and oversight. We use that to support our systems advocacy and also our public education, including the ability to do programs such as today's and our monthly webinars. And last but not least, we are the proud home, I should say, to two local long-term care ombudsman programs in the Hudson Valley of New York. All of our resources are available for free on our website, www.nursingHome411.org. Today's guest speaker. So this is really interesting for me, and I believe it'll be interesting for you as well. I've noticed in particularly nursing home advocacy, but also to some extent thinking about our assisted living, adult care facility advocacy as well, that there is a lot going on with the Medicare program. Obviously, concerns for many in terms of access, et cetera, raised with the most recent federal budget bill. We'll see some repercussions of that down the road, of course. But in particular, what our guest speaker is going to talk about today is Medicare Advantage. And it's not something that I know a lot about, so I'm looking forward to learning more about it myself today. But also, I think it's a matter of growing concern because more and more individuals are being urged to join Medicare Advantage plans, and they may not always, quite often, frankly, don't always provide the access to care and services that individuals need in the way that they, I would say, have the right to access them. Our speaker today is David Lipschutz. He is the co-director of the Center for Medicare Advocacy, and the center is the leading organization in the country advocating on Medicare rights issues and Medicare policy, in particular Medicare policy issues. Of course, David joined the center in 2010. He's been a co-director, I think, for a little bit over a year. Is that right, David?
That's right.
Throughout his career, he's worked on public policy issues. He is frequently quoted in a number of the prominent news outlets across the country. And it's really just an honor to have anyone from the center, but especially David, joining us here today to talk about these issues. So with that, I'm going to stop sharing and hand it over to David.
Well, thank you so much, Richard, for the very kind and undeserved introduction. I'll just pause a moment here while the screen switches over. Let me know when you start seeing my screen.
We can see it.
You can see it? Okay,
Yeah,
great.
thanks.
Well, again, thank you, Richard, and thanks to LTCCC for the invitation to be here today. We appreciate our longstanding partnership and our ongoing work with each other. My organization, as Richard said, the Center for Medicare Advocacy. We are also a nonpartisan nonprofit organization. If you are familiar with us at all, it is likely due to my colleague, Toby Edelman, who does so much work in long-term care space and has for many decades. He's really a pioneer and an outstanding advocate that I'm proud to work with. As far as what we will cover today, we're going to go basic. We're going to start with a quick overview of Medicare, then talk about the current enrollment period that we are in now, time during which people can make certain changes to their Medicare coverage. Then we're going to talk about some of the trade-offs between Medicare Advantage and traditional or original Medicare. Spend just a couple minutes talking specifically about a type of Medicare Advantage plan, the institutional special needs plans. Then we're going to talk about Medicare coverage of nursing facility stays, skilled nursing facility stays, and then touch on Medicare appeals. I included way more slides in the slide deck than we will have time to go over, and I will very likely make very short shrift of the appeals slides in particular at the end, but included them here for your reference, including some resources and links to resources both on our website and elsewhere. So we're going to start with an overview of Medicare and the current annual enrollment period. So Medicare is a federal program which covers over 68 million older adults and individuals with disabilities. It's divided into 4 parts, parts A, B, C, and D. Parts A and B form the core of the Medicare program, and together comprise what's typically known as original Medicare, also known as traditional Medicare, sometimes referred to as fee-for-service Medicare. Part A and B and traditional Medicare are the default, but most people have Medicare plus something else, or in the case of Medicare Advantage, replaces their Medicare. So we see here from this chart the different parts of Medicare. Parts A, also known as hospital insurance, it covers hospital, skilled nursing, home health, and hospice. Part B of Medicare, also known as supplementary medical insurance, covers physician visits, durable medical equipment, tests, and other things. In order to get prescription drug coverage in Medicare, you have to enroll in a private plan, either a standalone Part D prescription drug plan, or if you are in a Medicare Advantage plan, a Medicare Advantage plan that offers prescription drug coverage. So I noted that most people have Medicare plus something else. And here, this slide, it references Medigap, Medicare supplemental insurance. It's a common way that people who can afford to do so will supplement their traditional Medicare. But now, more than half of the Medicare population is enrolled in private Medicare Advantage plans that really replace your Medicare for as long as you are in those plans. And those plans combine Parts A and B coverage. Most of them offer Part D prescription drug coverage. And as we'll talk a little bit more about later, often offer additional benefits that are unavailable in traditional Medicare, such as some dental, vision, and hearing benefits. So, Medicare Advantage plans are able to offer those extra benefits in part because they are paid at a higher rate than what traditional Medicare spends on a given beneficiary. And the estimates of Medicare Payment Advisory Commission in the neighborhood of about $84 billion in excess payments to Medicare Advantage plans, in part because some of their payment is based on how sick their enrollees are. So there's a significant incentive for them to report their enrollees as being very sick. But as we've seen from different government reports and analyses, oftentimes their enrollees aren't actually treated for conditions that are identified in order to get more payment from the Medicare program. Medicare is not free, nor is it comprehensive. Most people don't pay a premium for Part A, but most people do pay a premium for Part B, which is about $185 this year. We do not yet have the A and B premiums and cost sharing amounts for 2026. Higher income individuals will pay more in premiums for Part B and D. Lower income individuals who qualify for certain programs can have their premiums covered primarily by the Medicare savings programs. So if anyone here happens to own a television and has turned it on in the past few weeks, you will undoubtedly be aware that we are in the Medicare selling season. We are in the annual election period that started on October 15th and goes through December 7th. This is the period of time during which a Medicare beneficiary can make changes to their Medicare Advantage coverage or their Part D coverage. It's not generally a time when they can make changes to a Medigap policy, a Medicare supplemental insurance policy, nor is it time generally that they can make changes to Parts A and B. So during this current enrollment period that we are in, individuals can enroll in a Medicare Advantage plan, change from one Medicare Advantage plan to another, change from a Medicare Advantage plan to traditional Medicare, and at the same time pick up a standalone Part D plan, or can change Part D plans. The enrollment is effective no matter when you make this decision during this period. The enrollment is effective January 1st. And there's a tool at the Medicare.gov website, the Medicare Plan Finder, that allows comparisons between Medicare Advantage and Part D plans. It is not always most up-to-date information, but it's the best tool that we have out there. If a Medicare beneficiary is already in a Medicare Advantage plan or a standalone Part D plan, and they do nothing during this time period, they're going to roll over into the same plan for 2026. Note that a number of Medicare Advantage plans are pulling out of certain service areas. And that means sometimes if the plan sponsor, the parent insurance company, offers additional plans in that area, people will be moved over to those plans if they do nothing. Or if there aren't other plans offered by the same insurance company, they're going to have to affirmatively make a choice, pick another Medicare Advantage plan or return to traditional Medicare. A quick note, if you're in one of those areas or know folks in those areas in which the Medicare Advantage plans are pulling out, that can trigger what's known as a guarantee issue right to pick up a Medigap, Medicare Supplemental Insurance Plan. Now, assuming many of you are based in the state of New York, that's not as big of a deal for you because your state law supplements federal law to allow much more generous Medigap enrollment rights, as does neighboring Connecticut, a little bit with Maine and Massachusetts as well. So it's worth mentioning that in addition to this annual election period, time when most people can make changes to their Medicare Advantage or Part D coverage, people who start the year enrolled in a Medicare Advantage plan will have another bite at the apple. During the first 3 months of the calendar year, folks who start the year in Medicare Advantage can make an additional change. They can switch to another Medicare Advantage plan, or they can go back to traditional Medicare and pick up a Part D plan. Note that that same right does not exist for people who are in traditional Medicare and who have standalone prescription drug plans. There is no similar right to change those prescription drug plans during the first 3 months of the calendar year. And then to wrap up our discussion on enrollment periods, it is also worth noting that there are certain instances that trigger so-called special enrollment period rights, or SEPs. The general rule is if you're in a Medicare Advantage or Part D plan, you cannot make a change during the course of the calendar year, except during this annual election period, except if you're in a Medicare Advantage plan, that open enrollment period for the first 3 months. But there are other certain events, like you move out of the service area or your plan is terminated. There's a long list of special enrollment period rights that are available in this linked document here. But in the context of long-term care, it is worth noting there is a special enrollment period for institutionalized individuals. That's the Medicare program's name for it. It's a continuous period for individuals who move into, reside in, or move out of an institution, and it ends 2 months after the month an individual moves out of the institution. So if you are a resident of a long-term care facility, you very likely have a special enrollment period right outside of the periods we just talked about to enroll in a plan or get out of one. Now, it must be said that there is not free movement between the different types of coverage options in Medicare. They are not equally available, namely between Medicare Advantage and traditional Medicare. There are many factors that push people towards enrollment in Medicare Advantage plans, including attractive extra benefits that Medicare Advantage plans provide with extra money that they get from the federal government, massive advertising budgets that you are all victims of, as all of us are during this time of year, and agent and broker commissions that pay a lot more for Medicare Advantage enrollments than they do for Part D plans or Medigaps even combined. And in many ways, enrolling in Medicare Advantage is a one-way street. You can change Medicare Advantage plans on an annual basis, but while people can return to traditional Medicare, in most states, not including New York, most people will not be able to later pick up a Medigap policy. Again, New York has good protections in state law that do allow people more rights to pick up Medigap policies than in most other states. And some people's choices made for them. Some retiree and union coverage exclusively put their retirees or members in Medicare Advantage plans. We know that folks in the city of New York recently won a battle pushing back against being forced into a Medicare Advantage plan. That, unfortunately, is uncommon. So many people are actually forced to enroll in a Medicare Advantage plan if they want to have any coverage from their former employer or union. With the setup, the system that we have that relies on so much private plan involvement, whether it's Medicare Advantage plans or standalone Part D plans, there are changes to these plan benefits each and every year. They can change their premiums, their cost sharing, their coverage and coverage rules, the types of extra benefits that they offer, the contracted provider networks, drug formularies, etc. So this entire private plan system that makes up the Medicare ecosystem relies on an active annual engagement of informed consumers maximizing their coverage options, which in reality doesn't happen. Most people don't do the homework every year. Most people don't compare plans. And as a result, many people are not in or don't have the type of coverage that would best suit their needs. So that's a quick snapshot of Medicare and the enrollment periods and different opportunities to make changes to your Medicare coverage. Now, let's focus a little bit on the trade-offs, because absent, being forced into a Medicare Advantage plan through an employer or union, or absent not being able to afford, say, a Medigap policy or standalone Part D policy, many people have a very important decision to make when they're first eligible for Medicare and thereafter as to whether or not they want to be in a Medicare Advantage plan versus traditional Medicare. And there are pluses and minuses of each option. As outlined in this slide, some of the potential advantages of being in a Medicare Advantage plan is that it's really the path of least resistance. It's one-stop shopping. Someone enrolls in a Medicare Advantage plan, they don't need to pick up, and can't in most cases pick up, a standalone separate Part D plan. They can't pick up a separate Medigap plan. Medicare Advantage plans, because of the excess of payments that they get, are able to keep their premiums low or at $0. A lot of Medicare Advantage plan sponsors said they're pulling back on benefits this year and pulling out of certain areas, but there are still many plans that are offered for zero premiums because the insurers know that's a very attractive option for individuals. They typically offer additional benefits with the excess money that they get, and most commonly dental, vision, and hearing. In recent years, that's been expanded more broadly. Note that with these supplemental benefits, they are not standardized, meaning it varies considerably between the plans and what options people have. Worth noting, there's much more information on all of this on our website, but in recent years, Medicare Advantage plans have advertised so-called flex cards. These are cards almost like debit cards that many plans offer that allow beneficiaries or enrollees to make certain purchases, whether it's grocery items or pay for cost sharing. And many people are understandably attracted to plans that offer these cards and shop around plans just based on the dollar value of the card that they're given. We strongly suggest that people do not use this as their motivating factor to enroll in a given plan, and that there are much more important factors that people should consider. By law, Medicare Advantage plans are required to cap enrollees' out-of-pocket expenses. For this year, 2025, for HMO enrollees, that can be as high as $9,350. And with PPOs, preferred provider organizations that combine in-network and out-of-network cost sharing, that could be as high as $14,000. Now, having gone through those advantages, there are also significant disadvantages to enrolling in a Medicare Advantage plan, starting with limited provider networks. Medicare Advantage plans have the ability to limit who you can see as a provider of services. This is critical if you reside in a facility. If you are in a Medicare Advantage plan, you need to make sure it contracts with the facility that you are in. The flip side is that the plan or plans that your facility contracts with might not actually be the best option for you, given the rest of the structure of the particular MA plan. In traditional Medicare, you can see whatever provider is willing to take you across the country. But Medicare Advantage plans, as a cost-saving measure, can generally limit who you can see. There's some variation in that. HMOs typically only allow you to see folks out of network under emergency or urgent situations, whereas PPOs, preferred provider organizations, generally have a contracted network, but do allow you to see providers outside of the network, usually for more cost sharing. There are different, plans that do offer broader networks and allow you to see people in other states, but the general rule is Medicare Advantage plans will restrict who you can see as a provider. For individuals with chronic conditions, seeing the right providers, including specialists, is often critical, including for folks who need to, maintain or slow their deterioration if they have a condition that is impacting their functionality. More and more providers and health systems are walking away from Medicare Advantage plans because of frustrations with wasted time and denied care due to prior authorization and lower reimbursement rates. And note that just because your key provider or providers might contract with a given Medicare Advantage plan now is no guarantee that that will remain so. And there are problems even when people do their due diligence and look at provider networks. Just yesterday, there was a story published in KFF Health News that talked about how a report from the Office of Inspector General found that 55% of mental health professionals listed as in-network in Medicare Advantage plans were not providing such care to any of the plan's members. Which is rather startling. The provider directories are notoriously inaccurate. The Medicare Plan Finder for the first time this year allows people to search the different plans based on the provider that you see. I would strongly suggest contacting the provider's office directly to see if they contract with any Medicare Advantage plans. Sticking with the disadvantages, we're going to talk more about prior authorization next. But some of the other disadvantages are that despite the fact that Medicare Advantage plans generally have zero or low premiums, someone in those plans could actually end up paying more for their services once they actually use services. There's a general rule that Medicare Advantage plans have to make their cost sharing actuarially equivalent to traditional Medicare. That essentially means at the end of the day, someone in a Medicare Advantage plan can't be projected to spend more than someone in traditional Medicare would for the same services. But traditional Medicare often charges, 20% coinsurance, for example, for chemotherapy, as do many Medicare Advantage plans. When it comes to drug plans, there's no cafeteria option. You can't pick and choose what drug plan you want with your Medicare Advantage plans, kind of take it or leave it, a package deal. And as previously noted, there is a limited ability once you're in a Medicare Advantage plan for a while to switch back to traditional Medicare and pick up a Medigap policy, again, except for places like the state of New York. So Medicare Advantage prior authorization is one of the biggest hurdles to care encountered by Medicare beneficiaries. Prior authorization is a process that plans can use to make sure that the care provided to enrollees is medically necessary, not unnecessary or wasteful, so the argument goes. It's meant to weed out unneeded care. But the flip side, of course, is that it can also prevent people from accessing medically necessary care. And that's what we tend to see based on where we sit. Traditional Medicare does have very limited instances of prior authorization. There's a new demonstration that's been launched that going to try to expand that, not yet applicable to New York. But when it comes to Medicare Advantage, nearly all plans use it extensively, particularly for higher cost items and services. The slide notes a recent KFF study that quantifies how often prior authorization is used. There's also a reference to an Office of Inspector General report that tried to quantify how often it is used inappropriately. Now, granted, people only contact us when things go wrong with their plan, but things seem to have gotten worse in recent years, even with efforts by the Medicare program to restrict inappropriate plan activities. So in short, prior authorization can be a major barrier to care, particularly for those with chronic conditions. And one takeaway is that if you are in a Medicare Advantage plan and have care denied that you believe should be covered, we always say fight it and appeal it. Unfortunately, few people do actually appeal, but when they do, they tend to be successful, which suggests, as the KFF data shows, that perhaps prior authorization is being used in an overly restrictive manner. Now, something from our standpoint almost worse than denials of care due to prior authorization are instances when care is initially authorized. It's the plan, Medicare Advantage plan will say, okay, we'll provide your requested care, but then the plan cuts it off prematurely before it's clinically appropriate. And this we've seen the most in the skilled nursing facility setting. Sometimes this premature termination of care is driven by contractors or vendors that contract the Medicare Advantage plan and employ algorithms or AI technology to help them make coverage decisions. That's been getting quite a bit of attention lately, understandably, in part because some of these same vendors are projected to be used by this demonstration in traditional Medicare that would expand prior authorization there. So we often see scenarios when a Medicare Advantage plan will grant someone some coverage in a skilled nursing facility because it's pretty hard to argue against the care that the person needs at the time. But then the plan will step in and try to terminate that care prematurely. And oftentimes the skilled nursing facility itself and the providers there disagree with the plan's decision about terminating care at that time. We have assisted individuals who have had multiple denials. Now, remember, most people don't appeal when they're denied care, but in these situations, when people do appeal, oftentimes they're successful because the plan is being overly restrictive in its care. We've often found that if someone uses the expedited appeals process and is successful, that means their appeal overturned the plan's decision to toss you out. The plans won't hesitate in turning around and issuing another denial, usually a few days after. Sometimes we've seen it as soon as the next day. Now, there's someone successfully appeals a denial, the next day they'll get another termination notice from their plan. We have seen people with multiple denials during that same episode of care, as many as 10 denials and successful appeals, and then a denial before the person, finally lost in an appeal. Now, perhaps in recognition of this, the Medicare program did recently put out some revised language to plans when it comes to appeals in this situation, and it's quoted here in the slide. When Medicare Advantage enrollees request an expedited appeal, the plan then has to put out a more detailed notice that explains why the plan is terminating your coverage. And the Medicare program revised the instructions to plans for those more detailed notice as quoted here and state that if an enrollee has previously received a favorable decision, appeal decision, during the current episode of care, the plan is instructed to detail the specific change or changes in the enrollee's condition since the previous appeal that provide the basis for the decision to terminate services. In other words, the plan has to show its work. The plan has to show, well, we're issuing another denial, even though we got slapped down by the adjudicator in Medicare, because reason X, Y, and Z. And it's often that exact reason that is missing from Medicare Advantage plan decisions. So if you're dealing with a situation where you're seeing multiple appeals, use this language. We also developed, because we've saw so many scenarios with multiple appeals during the same episode of care, a grievance form that folks can use if they so choose to file with the plan that then is supposed to be reported to the Medicare program, questioning the inappropriate and multiple appeals. So as mentioned earlier, providers are not that happy with Medicare Advantage on the whole. Many providers, including skilled nursing facilities in particular, complain that they aren't paid enough relative to what traditional Medicare pays. And they have to deal with owners' prior authorization requirements and documentation requirements. And despite the growth of Medicare Advantage, there also seems to be a growing trend of providers saying that they will not contract with Medicare Advantage plans. So now we're going to spend a few minutes talking about a particular type of Medicare Advantage plan, institutional special needs plans. So there are different types of Medicare Advantage plans in structure. There are HMOs that usually use contracted closed networks. There are PPOs that usually have a contracted network and allow people to go outside that network for higher cost sharing. There are medical savings accounts and private fee-for-service plans, both of which have very few people enrolled, but are kind of different structures in the way that the plans provide care. And then there are what are known as special needs plans that were created by federal law in 2003. And there are three types of special needs plans in the Medicare program. There are dual eligible special needs plans, which by far have the most people in them among the special needs plans. There are chronic care special needs plans. These are plans that are designed to treat people with a particular condition or conditions as articulated by the plan. In other words, this is a plan for people with end-stage renal disease, or this is a plan with people for diabetes. And there are also institutional special needs plans, or ISNPs. These are for people who need long-term care or live in the community, but need a long-term care level of care. And as we'll see in the next slide, most of the people who are enrolled in ISNPs do reside in facilities. Now, ISNPs, and that's the abbreviation for Institutional Special Needs Plans, provide Medicare covered services only. That's contrasted with say, dual eligible special needs plans, because those are specifically designed for people who are duly eligible for Medicare and Medicaid. And Medicaid tends to cover services that are not covered by Medicare. And the idea is it's supposed to blend the two types of coverage, Medicare and Medicaid. But ISNPs are really generally limited to what Medicare covers. That includes Part A skilled nursing facility stays, and that also includes for people who aren't necessarily in a Part A covered stay, but are getting, say, skilled therapy services covered under Part B. Kind of the main idea behind ISNPs is that they use plan staff either to deliver care directly on site in nursing homes to enrollees of the plan, or in partnership with the staff employed by the nursing home, or support care coordination of ISNP enrollees off-site with an eye towards trying to prevent unnecessary hospitalizations. That's one of the main drivers of skilled nursing or ISNPs, is that in theory, it uses these additional clinicians, usually in the form of nurse practitioners, to provide more individualized care in an attempt to prevent people from going to the hospital unnecessarily. That, as we'll talk about in a moment, doesn't always work out as planned. Previous data, pretty old data from 2013, because we don't know that much about ISNPs, and we'll see in the next slide that there aren't that many people in them. And that's part of the reason. But data from 2013 showed that ISNP enrollees had fewer hospital readmissions than expected, given people the severity of the conditions that people had. But at the same time, ISNPs had higher rates than other types of Medicare Advantage plans for use of potentially harmful drugs and drug combinations, I think namely antipsychotics, which does not bode well for overall quality outcomes. Now, as noted, we don't know a lot about ISNPs, in part because relatively few people are enrolled in such plans. Out of the more than 34 million people in Medicare Advantage, as of 2024, only about 125,000 people were across the country were enrolled in ISNPs. What we do know about them in part comes from MedPAC, the Medicare Payment Advisory Commission. We know that of people in ISNPs, the vast majority are residents of long-term care facilities, as opposed to living in the community. We know about roughly a third of all ISNP enrollees are enrolled in United Healthcare plans. We know that larger for-profit and urban nursing homes are more likely to participate in ISNPs, and Black Medicaid recipients and urban residents are more likely to enroll in ISNPs. We know that long-stay residents cannot enroll in an ISNP unless they live in a facility that participates in the plan's provider network. That facility has to contract with the ISNP in order for an individual residing in that facility to join. And nearly all nursing homes that do participate in ISNPs work with a single insurer, meaning they only contract with one plan, often United Healthcare, making it less likely that such a plan would actually be the right one for you. Now, this past May, an article in The Guardian came out with explosive allegations from a whistleblower surrounding United Healthcare and their ISNPs, including allegations that United Health is using bonus programs to encourage nursing homes that contract with United Health subsidiary Optum to keep hospitalizations of nursing home residents enrolled in ISNPs below a set threshold. And that goes far beyond just the idea of trying to prevent unnecessary hospitalizations. This, according to these allegations, is you as an ISNP in a facility with an ISNP need to keep, a certain number of people below a certain number of people that are sent to the hospital. These reports allege that these incentive schemes drive delays in medically necessary hospitalizations and emergency room visit, produce poor health quality outcomes, and even some permanent harm among ISNP enrollees who suffered, according to the article, strokes and other major health events without being hospitalized because the incentives were to prevent people from going to the hospital. Further, the same article alleges that United Health and its subsidiaries aggressively push the same ISNP residents to sign advance directives that stipulate do not resuscitate and do not intubate orders, which can, of course, prohibit hospitalization in the case of adverse events. Now, in Connecticut, we have seen, firsthand reports of people who reside in facilities and who have had nursing facility administrators sign on their behalf as authorized representatives to allow marketing visits to them, things that the enrollees or that the residents did not consent to themselves, nor did their actual legally authorized representatives. This, of course, is a troubling trend. We're looking more into it and trying to see how widespread this might be. This slide also contains a letter that was written by Senators Wyden and Warren to United Health Group in the wake of this Guardian article seeking more information from United Health. And to quote from the letter, quote, "Put simply, these allegations suggest that United Health Group appears to be prioritizing its bottom line at the expense of the health and safety of nursing home residents enrolled in United Health ISNPs. Nursing home residents and their families should not live in fear of a for-profit healthcare company withholding care when it is most critical." So this slide includes a couple of articles that my colleague Toby Edelman wrote about ISNPs, including comments back to MedPAC and pointing out conflicts of interest with respect to nursing home operators that offer their own ISNP. So now, just to make sure we're all on the same page, I wanted to talk a little bit about what Medicare does cover when it comes to Part A skilled nursing facility stays. So Medicare can cover skilled nursing facility visits under Part A, which is what we're going to discuss. But remember that Medicare can also cover more discrete services minus room and board under Part B. And that includes, for example, PT, OT, ST, physical therapists, occupational therapists, speech language pathologists, or therapists rather, under Part B of Medicare, even if someone is not in a Part A covered stay. In order for Medicare to cover a skilled nursing facility stay, certain criteria has to be met. There has to be a physician certification. Under the law, there has to be a 3-day prior inpatient stay in a hospital. And note that emergency room visits and stays under observation do not count towards that 3-day requirement. Most Medicare Advantage plans, however, waive that 3-day prior hospital requirement. So in theory, it's possible for most Medicare Advantage enrollees to get a covered stay in a skilled nursing facility, even if they haven't had that prior 3-day inpatient stay. Now, for those in traditional Medicare, there's a lot of stuff going on behind the scenes in efforts to try to improve quality and delivery system reforms, and a number of people are in so-called accountable care organizations. They might not even realize that they are. But some of those accountable care organizations that people are in traditional Medicare also have the ability to waive that 3-day prior hospitalization, but that's only really a benefit to those people who are attributed to those ACOs if they're aware of it and if they happen to go to a nursing facility that contracts with the ACO. Also, in addition to the physician certification, a 3-day prior stay, generally an individual must enter a skilled nursing facility within 30 days of a hospital discharge, unless it is not medically appropriate to begin a course of treatment until beyond 30 days. Medicare can cover up to 100 days in a skilled nursing facility during a benefit period. And a benefit period essentially is refreshed once someone has been out of both the hospital and a nursing facility for at least 60 days. So it's possible to have multiple benefit periods in a given calendar year. It's rare that people get 100 days of covered care in a skilled nursing facility. Usually it's a few weeks, sometimes a couple months. Under traditional Medicare, there's no deductible or copayment for the first 20 days, but a copayment does kick in around day 21. And remarkably, a lot of people in traditional Medicare are kicked out of the facility right around day 21 when copays are due. Medicare will pay if an individual receives daily skilled care. That's one of the key tests of Medicare coverage of nursing facility care is daily skilled care. Must be medically reasonable and necessary, can be safely and effectively performed only by or under the supervision of the professional or technical personnel. Note that daily is defined as 7 days a week of skilled nursing or therapy or 5 days a week of therapy. And I think the recognition there is that most therapists tend not to work on the weekends, so it counts, work during the week, 5 days instead of 7 in order to meet that daily requirement. Note that improvement of a condition is not required for coverage. This speaks to the so-called improper improvement standard that was the subject of our litigation with Vermont Legal Aid, known as Jimmo versus Sebelius. And I think LTCCC has a fact sheet that they're making available that touches more on this so-called improvement standard. This slide just kind of encapsulates everything we talked about in a chart form in case folks are more visual learners. So the last section here is on Medicare appeals. And again, I am not going to go over this in detail, but we'll say a few words before stopping and before we turn to further input from Richard and some Q&A. So in Medicare, there is an administrative appeals process that allows people to challenge denials of care or terminations of coverage. It has 5 steps following an initial decision, and that's true if it's in traditional Medicare, that's true if it's Medicare Advantage, or in Part D. So the initial decisions are called different things. Usually in traditional Medicare, this comes after the fact, after you've received the services from a provider. The claim gets submitted to Medicare. Medicare issues a Medicare summary notice that says, nope, we're not going to pay for that. And that will trigger an appeal right. Medicare Advantage, it can happen either if a person requests a service and the plan denies it, they deny a prior authorization or prior approval request, or as we talked about earlier, services are authorized, but then it's terminated. That triggers a right in Medicare Advantage as well. So the 5 different steps, they have different names at the first 2 levels. At the 3rd level and beyond, they have the same names. The 3rd level, administrative law judge hearing, is where beneficiaries usually have the best shot at being successful. However, when it comes to terminations of care that are subject to expedited appeals, touch on briefly next, the appeals process only really functions for the first couple levels of appeal. If you're going beyond that, it's usually dealing with care that has already been provided, but you're seeking coverage for. Now, the 3rd and final levels here, there's a note that says AIC. That stands for amount in controversy. And what that means is, in order for you to have a right to go to an administrative law judge hearing, there has to be a certain amount of money at issue, the value of the services or items in question. For this year, that's $190. And when we're talking about nursing facility care, it's very easy to meet that standard. In order to get to the last level in federal court, that amount is $1,900. So again, with Medicare appeals, there are kind of 2 different types. There are standard appeals and there are expedited appeals. Expedited appeals can be available when services are terminated, whereas standard appeals are generally for coverage and claim payment. And in traditional Medicare, after the fact, and for Medicare Advantage, prior authorization. If you don't have the services yet, you have pre-service denial, unless you can articulate that it was a danger to health, and you have support from a clinician saying that, then chances are your appeals will be in the standard time frame, which takes a little longer. The exception to that kind of automatic exception is if you're in a hospital or a nursing facility in home health or hospice, and the provider tells you, or the plan tells you, we're terminating your services. That automatically triggers an expedited appeal right. So I'm just going to scroll through these last slides a little bit. This is here for your information. It has information on expedited appeals in traditional Medicare, as well as in Medicare Advantage, along with some links. There are also some resources here and citations to where you can find the Medicare rules and law. Here is a link to our website that includes a lot of self-help materials, including with respect to appeals of skilled nursing facility denials and discharges. It looks like I inadvertently deleted the name of a webinar. Earlier this year, in April, we had a Medicare Appeals 101 webinar. If you go to our website, you should be able to find it, and you can watch that if you are so inclined. So I will stop there and see if Richard or Haley have anything else they want to weigh in with, and then try to tackle some questions if there's time.
David, thanks so much. That was a lot of information and really clear. I learned a lot. I think everyone else did too. I'm just going to quickly share my slides. Now, of course, I'm getting a desktop, so let's see
Sure.
if I can move that around.
Mhm.
And there we go. So our next webinar will be November 18th, again at 1 p.m. And our guest speaker will be Professor Elon Musk. And he's going to be talking about staff fear of retaliation. A
Sorry,
barrier.
Richard, not
Oh,
Elon Musk.
oh my God,
Elon
Elon
Caspi.
Caspi. Thank you. Oh my goodness.
No
Whoa.
problem.
Thank you, Elon Caspi. Shame on me. Elon Caspi, who's a longtime friend of the coalition and a terrific researcher and advocate. He's done a lot of work on fear of retaliation in nursing homes and in assisted living. And this is going to be specifically on his work around staff's fear of retaliation regarding reporting abuse and neglect in nursing homes. Again, that's November 18th. And then head to our website, nursinghome411.org. The materials from today's webinar are on the website now. We'll be adding this recording, excuse me, of the presentation by the end of the week. Follow us on social media. We're on Facebook, Instagram, Blue Sky, and X. And then, of course, visit our website. In particular, our Learning Center has information on and data on U.S. nursing homes, including staffing levels. We have fact sheets on nursing home care standards, assisted living guides, whole family empowerment resource center, and the resident abuse, neglect, and crime reporting center. And without further ado, I'm going to stop sharing. And we have some questions for David. And I'm going to go first. I'm going to use the host prerogative. He spoke about a few states, New York and Connecticut among them, having some additional protections. I was wondering if there's a list anywhere that you know of states that have additional protections for consumers.
Yes, sure. Then that specifically relates to Medigap, Medicare supplemental insurance
Okay.
policies. And so the federal law creates a floor of rights that has to be followed in all states. But when it comes to Medigap rights, that's one of the few areas where states can add on protections because mostly states are preempted from doing anything relating to Medicare.
Ah,
So that's specifically with rights to purchase a Medigap policy. And those four states are New York, Connecticut, Maine, and Massachusetts.
ah,
Now, many other states add additional rights for folks, like some triggering events that will precipitate a guarantee issue right. But those four states, including New York, are really the only ones that allow people on an annual basis at least to purchase a Medigap policy. The general rule is that Medigap issuers can legally discriminate against you based upon your health condition, even after the Affordable Care Act, unless you are trying to purchase a policy during certain select time periods, including when you're first eligible for Parts A and B. So
ah,
those consumer protections really limited to the Medigap
wow.
issue.
Wow, thank you. Very interesting. So our first question is from Margaret Farley. Hi, Margaret. Nice to see you on. She has a scenario. In 2025, person loses Medigap due to failure to pay premium timely. In 2026, can that person re-enroll in Medigap?
My knee-jerk reaction is they can try, but they might not necessarily have a right to do so unless they live in New York or one of those four states. I think that person should be able to exercise their right to purchase a Medigap. Might not be for the same one, might not be the same company, might not be at the same price, but if they live in one of those states, there could be an opportunity to purchase one.
Margaret's in Kansas, I believe.
Then yeah, Kansas is not one of those states. I don't know what additional rights Kansas has added, but then I don't believe in that scenario someone would be guaranteed a right to pick up one.
Thank you. Anonymous attendee asked, are there state agencies that a patient can complain to if their Medicare Advantage plan engages in repeated denials of appeals?
Well, because federal law preempts state action in many areas, there's not a whole lot that states can do. There's state departments of insurance, or some states have their own Department of Managed Care. They are responsible for licensing and assuring the fiscal solvency of a given Medicare Advantage plan. But when it comes to regulation, and doing something about it and imposing, sanctions or other oversight, states are pretty limited. One area where they do have more leeway is when it comes to agents and brokers and their activity, because the states also license agents and brokers, and I think they're more receptive to taking complaints about them. But when it comes to Medicare Advantage plans and their conduct, say inappropriate denials of care, there's not a whole lot that the state entities can do. Now, that doesn't mean you shouldn't, lodge a complaint. I mean, the more people stay silent, then regulators, whether they're state or federal, aren't going to know that there are problems. So I think it's always a good idea to complain, but know that when it's at the state level, there's likely little recourse. I would go complain to your member of Congress, your U.S. senators, and to the Centers for Medicare and Medicaid Services.
Thank you. That's interesting. Um, Patricia Wahlberg asked, is there a specific amount of therapy time per day needed for the SNF stay?
If there is, that's a question I don't know the answer to off the top of my head, and I don't want to give you bad information. I think there are some outlines in the Medicare manuals. I would take a look at the Medicare benefit policy manual, the Medicare claims manual, but there might be an answer to that question, but I just don't want to give you the wrong one.
Thanks. And just to clarify, at least for myself, I mean, I read this question in two different ways. One is that, is there a specific amount of time that people are entitled to, or a specific amount of time that they need in order to qualify for a SNF stay? So I'm not sure if that changes your answer or not, but
yeah, I don't, I mean, as far as time that people are entitled to, I think that's largely at the discretion of the prescribing clinician. That's, that outlines what he or she thinks you need. But as far as there being a minimum time period, like, you need to have half an hour of therapy in order for the nursing facility to be paid for a Part A skilled stay, that I think is probably articulated somewhere in the manuals.
Thank you. Yeah, that makes sense to me. Anonymous attendee asked, if they are not in Medicare level of care, does that start the spell of illness? I'm not sure what that means. Yeah.
So that has to do with so the benefit periods and spell of illness. That's how a lot of the Part A coverage, looking at hospital coverage and skilled nursing facility, are covered. So a spell of illness lasts, usually started by a hospitalization, and someone goes into a nursing facility, and that spell of illness ends when someone is out of both the hospital or a facility. And the question is whether or not it's has to be a Medicare covered stay. I believe it does not. I think it's if a person yeah. Or actually here, I just pulled it up because I'm anticipating this question to brush up on it. A spell of illness begins when a beneficiary receives Medicare-covered inpatient hospital care and ends when the patient has spent 60 consecutive days outside the hospital or skilled nursing facility, or remains in a healthcare institution but does not receive Medicare-covered services for 60 consecutive days. So that suggests that, yes, it's Medicare-covered stay, in that the period can refresh if someone's in a nursing facility for 60 days but is not receiving Medicare covered stay during that time.
Interesting. So just one more question, if we can keep you for a few minutes, David.
Sure. Yep.
Larry Wiesler asked, what is the difference between Medigap and Medicare Advantage policies? For example, United Healthcare sells its Part G plan that I believe is a Medicare Advantage program.
So the difference between a Medigap and a Medicare Advantage plan, Medigap is another name for Medicare supplemental insurance, and those are individual policies that are lettered by the alphabet. So a G policy means that's a Medigap, that's a Medicare supplemental insurance policy. Those are designed specifically to track care in traditional Medicare. So in other words, when Medicare pays for something, depending upon the Medigap policy you get, that'll fill in some of the cost sharing or sometimes add additional coverage. Medicare Advantage, however, Part C of Medicare really replaces your traditional Medicare coverage. It covers Parts A and B services, and most of them cover Part D services. You cannot have both at the same time. You can't have a Medigap and a Medicare Advantage plan at the same time. So you are absolutely right. They're often offered by the same insurance sponsors. So they get you coming or going. They get you if you are in traditional Medicare because they can offer a Part D plan or a Medigap plan, and the very same carriers tend to offer Medicare Advantage. There is an incentive on their part to steer you towards Medicare Advantage. They make more money off of you, as do agents and brokers, if you enroll in a Medicare Advantage plan. You know, we see this all the time. Someone will be enrolled in say a standalone Part D prescription drug plan offered by Humana. Humana will contact that person who's in their Part D drug plan in traditional Medicare and will try to convince that person to switch to a Medicare Advantage plan offered by Humana because they get significantly more money for that.
Thank you. Yeah, I know, and I would encourage Larry and everyone else to please, check over the slides. They're available on our website because David laid that out really well before. But thank you, David, because that response was really interesting and helpful. Thank you, everyone, for joining us today. Again, thank you, David, so much. You were so clear, and this was really valuable. I appreciate it.
My pleasure. Thanks for having me.
Okay, bye, everyone. Have a nice afternoon.